Harley Gagan. I serve as the Advocacy Director for the American Lung Association. I cover both Texas and Oklahoma. I want to thank you all for joining us today. Everyone other than our speakers should be muted by the system, but please, if you wouldn't mind, just double check that. There will be an opportunity at the end for questions, and we will be using the Q&A box for those questions. Thank you all for joining us today at the end of National Cancer Survivor Month. Unfortunately, every 2.5 minutes, someone in the U.S. is diagnosed with lung cancer, and every day, lung cancer takes the lives of more than 356 of our friends, neighbors, and loved ones. So today, our goal is to talk about what is happening in lung cancer and how we can continue to make progress against this disease so that there are more survivors of lung cancer. Today's program, we will cover the American Lung Association's State of Lung Cancer Report's findings, followed by a discussion with local panelists based in El Paso, and then there will be an opportunity for questions. So please feel free to put questions in the chat box as we go, or you can wait until the end. As you may have noticed, today's webinar is being recorded, and we intend to share it on our YouTube channel and really hope that it's part of an ongoing conversation around lung cancer, both in El Paso and Texas, because to be honest, we have a lot of work to do. And so without further ado, I want to thank our sponsor for today's event, Genentech. We truly appreciate their continued support of the Lung Association, both in Texas and nationally. And so without further ado, we're going to jump right in. So the State of Lung Cancer Report was released last November. It is an annual report that shows the toll lung cancer takes on each state in the country. The report highlights several metrics, including rates of new cases, survival, early diagnosis, surgical treatment, lack of treatment, and screening rates overall. And this report indicates that states must do more to protect their residents from lung cancer. For the third consecutive year, the State of Lung Cancer Report explores the lung cancer burden among racial and ethnic groups at the national and state levels. And we hope this report serves as a guidepost and rallying call, providing policymakers, researchers, healthcare practitioners, as well as patients, caregivers, and others committed to ending lung cancer by identifying where their state can best focus its resources to decrease the toll of lung cancer. One big highlight of this year's report, more Americans than ever are surviving lung cancer. And over the past 5 years, the survival rate has increased 21% nationally to 25%. But it does remain significantly lower among communities of color at only 20%. Overall, the report does not yet reflect potential impact of the COVID-19 pandemic on cancer diagnosis, treatment, or survival, as the data in the report preceded the emergence of the coronavirus. So just keep that in mind. But first, let's talk about, what causes cancer. And really, there are a variety of risks associated with lung cancer, including smoking, exposure to radon gas, air pollution, and secondhand smoke. Tobacco use, specifically commercial tobacco use, is the leading risk factor for lung cancer. Smoking and secondhand smoke both have been shown to cause lung cancer. So commercial tobacco, your cigarettes, your cigars, your snuff, your snus, can contain more than 7,000 chemicals and is manufactured by companies to addict people to harmful products that cause death and disease. On the other hand, traditional tobacco has been used in sacred ways by Native peoples for centuries. And this report, and when we're talking about tobacco here, we talk specifically about commercial tobacco. And so looking at Texas, the smoking rate is 13% overall, not significantly lower than the national rate of 14%. As you can see, Utah actually leads the nation at the lowest rate, while West Virginia has the highest rate of smoking. Radon is the second leading cause of lung cancer, and radon is a colorless, odorless gas that can seep into some homes and buildings. Some geographical areas naturally have higher average radon levels than others, but since any home can be at risk for elevated levels, the only way to know is to do a test. And so if that testing shows interior radon levels at or above the US EPA action level of 4 picocuries per liter of air or higher, it is recommended to take corrective measures to reduce your exposure to radon gas. And the Lung Association encouraged such measures to be considered at levels at or above 2 picocuries. Fortunately, in Texas, only 8% of radon test results were at or above the action level recommended by the EPA, and that ranks Texas fourth among all states, placing it in the top tier. So while it is a concern, fortunately in Texas, it is a much lower concern than some other states. We also know that air pollution is a known risk factor for lung cancer, in particular, exposure to particle pollution. One of our other annual reports, the State of the Air report, looks at both ozone and particle pollution. And in the most recent report, we found that while El Paso has some serious work to do around ozone, we are generally seeing healthy levels of particle pollution. As you can see on the chart, El Paso's average annual particle pollution levels are below the threshold for poor air quality. Although I will note the Lung Association has urged the EPA to lower that threshold down from 12 to 8 or 9. So work can still be done overall to improve air quality in the El Paso area. So now that we touched on what causes lung cancer, let's switch gears and talk about the state of lung cancer. And here we see how Texas fared in each of our 6 categories. Now, before we delve into each of these, I wanted to provide a note on our methodology. So lung cancer incidence, staging, surgical treatment, and lack of treatment data is for the years 2015 through 2019 and includes both malignant and bronchus tumors. These data are based on the North American Association Central Cancer Registries December 2021 data submission. Support for cancer registries is provided by the state, province, or territory in which the registry is located. State survival rates are the age standardized percent of cases still alive 5 years after diagnosis for cases diagnosed in the years 2012 through 2018. And these data are from Cancer in North America 2015 through 2019, Volume 4, Cancer Survival in the US and Canada 2012 through 2018, also from the MAACCR. Screening rates were determined by dividing the number of screening exams meeting the U.S. Preventative Services Task Force criteria by the estimated number of people at high risk for lung cancer and recommended for annual screening with low-dose CT scans. The number of screening exams meeting that criteria came from the American College of Radiology's Lung Cancer Screening Registry for 2021. Lastly, the number of current and former smokers aged 55 to 80 for each state was estimated using the 2020 behavioral risk factor surveillance data from the CDC. So in the report, states were ranked from best to worst for each cancer-specific measure. So statements such as above average tier and above tier were determined by dividing each measure into essentially 2 sets of 5 contiguous data ranges. One set ranging from the maximum observed value to the national average, and the other from the national average to the minimum observed value. And so the 2 lowest categories are classified as bottom tier, and data in the 3rd and 4th lowest categories are classified as below average, data in the middle 2 being average, and those above average or top tier. So the first metric is new cases of lung cancer. Close to 237,000 people in the United States will be diagnosed with lung cancer this year, with the rate of new cases varying significantly by state. Over the past 5 years, the rate of new cases has actually decreased 11% nationally. So that is definitely a cause for applause. These are the number of new cases per 100,000 people of each state and the top 5 and 5 worst states. And so you can see there's a very big difference between our top states and our bottom states. There are nearly triple the number of lung cancer diagnoses in the bottom states compared to our top state, Utah. In Texas, the rate of new lung cancer cases is approximately 49 per 100,000, which is significantly lower than the national rate of 57 per 100,000. And so this ranks Texas 10th nationally among states, placing it in the above average tier. And over the past 5 years, the rate of new cases has improved by 11%. Unfortunately, this is the only metric where Texas is in the above average tier. As we move on to the others, you'll see we have a lot of work to do in all of our other categories. So next up, the 5-year survival rate. And here we look at the 5-year survival rate in each state, and we see much more geographical variance than we did with new cases. Lung cancer has one of the lowest 5-year survival rates because cases are often diagnosed at later stages when the disease is less likely to be curable. The national average of people alive 5 years after a lung cancer diagnosis is 25%, which, as I mentioned, is a 21% improvement over the last 5 years. And similarly, the gap between top and bottom states isn't quite as pronounced, but it is still significant. The percent of people alive 5 years after being diagnosed in Texas with lung cancer is 24%, which is just a bit lower than the national rate of 25%. And it ranks us 27th among the 45 states in DC where we were able to collect data. There is some hope, though. In the past 5 years, the survival rate in Texas has actually improved 16%. So again, we need work to do, but we are seeing improvement. This stage of diagnosis. So as you all probably know, most lung cancer cases are diagnosed at later stages when the cancer has spread to other organs and treatment options are less likely to be curative and survival is generally lower. In general, the earlier lung cancer is diagnosed, the more likely treatments will be effective and improve chances of survival. And so nationally, only 26% of cases are caught early when the 5-year survival rate is significantly higher at 61%. Unfortunately, most cases, around 44%, are not caught until a late stage when the survival rate drops down to 7%. And so this graph represents that national average. And in Texas, 23% of cases are caught at an early stage, the dark blue there, which is significantly lower than the national rate of 26%. And so that ranks Texas 43rd among 49 states with data, placing it in the below average tier. But again, over the last 5 years, the early diagnosis rate in Texas has improved by about 9%. And while surgery may not be an option for every patient, those who receive surgery as part of their initial treatment generally have higher survival rates than those who do not. Lung cancer can often be treated with surgery if it is diagnosed at an early stage and has not spread. Nationally, 21% of cases underwent surgery, which was a 4% improvement over the last 5 years. Rates ranged from the best at 31% in Massachusetts to the worst at 14% in New Mexico. Now, patients who are not healthy enough to undergo the procedure or whose cancer has spread may not be candidates for surgery, and other treatments may be recommended instead or in addition to surgery, such as chemotherapy, radiation, targeted therapy, or immunotherapy. So, but this report focuses specifically on surgical treatment because it is more likely to be curative. And so looking at Texas specifically, Texas ranked 45th out of 49 states with data at only 16% of cases undergoing surgery as part of the first course of treatment. Again, this is significantly lower than the national rate of 21% and puts Texas in the bottom tier. Over the last 5 years, the percent of cases undergoing surgery in Texas unfortunately did not change significantly. Now, there are multiple reasons why a patient may not receive treatment at all after a diagnosis. Some of these reasons may be unavoidable, but no one should go untreated because of lack of provider or patient knowledge, because of stigma associated with lung cancer, fatalism after diagnosis, or the cost of the treatment. And nationally, we saw, unfortunately, 21% of cases did not receive any treatment, but treatment rates have improved 15% over the last 5 years. Lack of treatment in Texas, unfortunately, we ranked 47th out of 49th, with 28% of cases not receiving treatment. This is significantly higher than the national rate of 21% and put Texas in the bottom tier. And unfortunately, again, over the past 5 years, the percentage of cases receiving no treatment did not significantly change. Now, lung cancer screening gives us hope in the effort to defeat lung cancer and represents an opportunity to save more lives. Screening for lung cancer with an annual low-dose CT scan is among those at high risk can reduce the lung cancer death rate by up to 20% by detecting tumors at an earlier stage when the cancer is more likely to be curable. But for screening to be most effective, we need more of the high-risk population to be screened annually. And currently, screening rates remain low among those at high risk. So nationally, only 5.8% of those at high risk were screened. And really, there's an incredibly large gap between the top and bottom states here, with Massachusetts having the best screening rate at 16.3%, while California has just 1%. And so just to kind of think about that, you are 16 times more likely to be screened if you're high risk if you live in Massachusetts than California. Based on new research, back in March of 2021, the United States Preventative Services Task Force actually expanded its recommendation for screening to include a larger age range and more current and former smokers, which the Lung Association and I know many other partners championed and supported. This will dramatically increase the number of women and Black Americans considered at high risk for lung cancer, but obviously they need to get screened. Being added to the criteria is one thing, actually getting screened in another. And so I will note that screening rates in this report are from before those guidelines were updated, so they do not yet reflect the screening among those newly eligible. And so here we see those expanded guidelines for screening to now include individuals ages 50 to 80 who have a 20-pack year smoking history and currently smoke or have quit within the past 15 years. And so when we talk about pack years, this means either 1 pack a day for 20 years, 2 packs a day for 10 years, etc. And so again, I wanted to alert folks, these are new criteria that just came out a few years ago, and they do greatly expand who is eligible to receive a screening. Now, unfortunately, in Texas, only 2% of those at high risk were screened, which is significantly lower than the national rate of 6%. And this, again, puts Texas in the bottom tier at a rank of 48th. For screening to be most effective in reducing the overall lung cancer mortality rate, we need more of the high-risk population to be screened. And currently, these screening rates are very low among those at high risk. Now, this may be because of a variety of factors. Could be lack of access or low awareness and knowledge among patients and providers. And the rates vary tremendously between states. So we know that more can be done to increase screening rates. Now, our report highlighted one specific disparity for Texas. And as mentioned, the percentage of Black Texans receiving surgical treatment is significantly lower than both the national average and the average for white Texans. So as you see here, Black Texans, only 13% receive surgical treatment, again, significantly lower than Black Americans nationally and their white counterparts here in Texas. Now, considering this webinar today is focused on El Paso, and El Paso is largely represented by Latino Texans, I did want to dial down a bit into what our report found for that demographic. So first, the good news. The rate of new lung cancer cases is 25 per 100,000, which is not only lower than the rate for Latinos nationwide, but significantly lower than the rate for other Texans. So that is obviously good news. Unfortunately, when we look at the percent of cases diagnosed at an early stage and those who did not receive any treatment, Latinos fared significantly worse than their national and Texas counterparts. So while 20% of cases were diagnosed early, that was lower than the rate of 23% among Latinos nationally and 24% among white Texans. Similarly, 32% of cases did not receive any treatment. And that's essentially 1 out of every 3 Latinos diagnosed with lung cancer did not receive any treatment. So again, a lot of work to be done. Now, our last metric is coverage of screening coverage. State Medicaid programs are one of the only healthcare payers not required by law to cover lung cancer screening for the traditional Medicaid population. If screening is covered, Medicaid programs may use various different criteria, prior authorization, or even charge for the scan. Now, as a result of the Affordable Care Act, most private insurance plans do have to cover the updated screening coverage policies to reflect the new guidelines that were introduced in 2021. Back in February 2022, Medicare finalized a similar policy expanding coverage of lung cancer screening, and that began that February. Now, the American Lung Association provided comments to the U.S. Preventive Services Task Force and Medicare throughout those processes to expand screening recommendations, and has produced a toolkit, which I'll cover at the end, to help stakeholders update coverage policies to reflect the latest guidelines. And those are available at lung.org/USPSTF-toolkit. Now, the American Lung Association analyzed cancer screening coverage policies in state Medicaid fee-for-service programs to assess the current status of lung cancer screening coverage for the Medicaid population. And we found that 46 Medicaid fee-for-service programs covered lung cancer screening, including Texas. 3 programs did not provide coverage, and 1 state we were unable to ascertain based on the information on their website. So as you can see in the graph here, Texas Medicaid does cover lung cancer screening and is using the updated guidelines. The big gap for Texas is that we've yet to expand Medicaid to the eligible population. And it's estimated that 1 million Texans would gain health coverage if Texas expanded Medicaid. Now, unfortunately, Texas leaders in Austin continue to decline to expand this life-saving program, and that is a key priority for the American Lung Association. So in summary, while the rate of new cases in Texas is lower than the national average, the state still has a lot of work to do to make sure that more of those at high risk for lung cancer are screened. Over the past 5 years, Texas has improved access to expanded screening by covering it through its fee-for-service Medicaid program. The Lung Association encourages all states to not only cover lung cancer screening based on all the latest guidelines across all plans, but to do so in a way without any financial or administrative barriers in their Medicaid programs. It is alarming that Texas falls into the bottom tiers for screening rates, as well as the percentage of patients receiving surgery and no treatment. And again, as we mentioned, while some patients do refuse treatment, there are often issues such as fatalism and stigma can prevent eligible patients from accessing treatment that may save or extend their lives. We encourage all patients to work with their doctors to establish a treatment plan and goals. And so now I'll introduce our special guests and begin a discussion. If you have questions for our guests, please put them in the chat box and I will answer them toward the end of the call. So first, I'd like to introduce Martha Zepeda with the American Cancer Society. Martha is the Associate Director for Community Partnerships with the American Cancer Society, with a mission to help improve the lives of people with cancer and their families through advocacy, research, and patient support, and ensure that everyone has the opportunity to prevent, detect, treat, and survive cancer. She's been working on this for 19 years, leading the cancer fighting organization with a vision of ending cancer as we know it for everyone. Martha, thank you for being here. Jessa Romero is a physician associate that currently practices family medicine with Project Vida Health Center, an FQHC in El Paso, Texas. She is a graduate of the University of Texas Health Science Center of San Antonio, physician assistant class of 2014, and currently serves as deputy medical director and is passionate about her work on the homeless community of El Paso on their mobile screening unit. Lastly, Dr. Jennifer Molokwu is an associate professor in the Department of Family and Community Medicine at the Texas Tech University Health Science Center of El Paso. She obtained a master's degree in public health at the University of Minnesota School of Public Health, and she is the program director of multiple Cancer Prevention Research Institute of Texas funded programs developed to improve breast, colorectal, and cervical cancer screening and prevent HPV-associated cancers. She currently serves as the vice chair for research in the Department of Family and Community Medicine and the director for Cancer Prevention and Control in the Department of Molecular and Translational Medicine Center and Emphasis in Cancer. Jennifer and Jessica, thank you also for joining us. And I'm going to stop sharing my screen and pull up my questions. And Jessica, if you're there, feel free to go ahead and come off mute. Let me make sure that I have you on the right settings. Jessica, can you hear us?
Yes. Can you all hear me?
Yes, we can. All right.
Awesome. Thank you.
So, Jessica, I'm actually going to go to you first. What stood out to you in our report?
The less than 2% screening in Texas. I think that was the big one. Less than 2%. I think it was 1.8 or 1.9% of patients at high risk are getting screened.
That's right. Actually, we actually rounded it up a bit, but it is less than 2% are getting screened. And so, Jessica, can you tell us a bit about the work Project Vida is doing to help lung folks with both smoking cessation and lung cancer screening?
This is a bit of a tricky question since a lot of our patients are non-insured. And so I think one thing that Project Vida does well is screen for tobacco use. So we do good at screening for tobacco use and referring patients to the quit claim. But for those who are at high risk, one thing that I know we need a lot of help in is getting these patients the actual low dose CT scans. So it's hard when more than half of our patient population is non-insured. And so it really becomes it's not a priority for patients to pay out of pocket for a low dose CT scan.
Yeah.
So while we're screening, we're not doing the actual screening for tobacco use. We're not doing the actual screening for lung cancer.
Absolutely. And obviously, it's critically important to help folks quit tobacco, but that second step of getting them screened can often be a big barrier. Thank you, Jessica. We're getting a little feedback from your phone. So if you wouldn't mind going on mute for just a minute here. Martha, I'm going to hand it over to you. Martha, what stood out to you in our report?
So, of course, that there's still a lot of work to be done. I think we all can agree with that. A lot of work to be done. I think that the recognition of not people knowing that they can get screened based on the criteria, that's why, the early diagnosis rates, are very, very low. And that's something that stood out to me because of the work that we're currently doing in El Paso, and across nationwide. But in El Paso, that's what really stood out to me. How can we get that number up?
Absolutely. And now I understand the American Cancer Society has an exciting program focused on the El Paso region. Can you tell us a little bit more about that?
Yes, of course. So the American Cancer Society, with partners of Hospitals of Providence, and I will say Project Vida, it plays a big role in this as well. We're leading that comprehensive and kind of multi-sector movement for lung screening in El Paso. We had 19 projects funded under the new interventions program for screening. This was really a program that was implemented after the pandemic. So I think we all knew that there was going to be a lot of late stage diagnosis, right, due to the pandemic. And so one of the focuses was lung cancer screening. And El Paso was one that got funded to help increase lung screening. One of two in Texas, as a matter of fact. And working with Hospitals of Providence, partnering with FQHCs like Project Vida, really has helped, and the engagement and the action behind it. It took us a little bit to get it started, but I will say major progress has been done. We incorporate the QI component, core team component to it, where, the leaders really developed a plan from, screening to, those who are diagnosed. And so that's it's still going on. Hospitals of Providence is still doing screening. So part of this project paid for either barriers to transportation. Like mentioned from Project Vida, patients who did not have insurance, were covered under the grant. The workflow, the process mapping behind it, as to how to get them to treatment for those who were diagnosed. I think part of that is the navigation component, where we see patients fall off, and one of the things that we did see were patients who got screened never followed up. And that's where we see that barrier. And we continue. Of course, there's many more barriers, but that is one of the most highest barriers that we saw getting the patient through the process. So especially in lung screening, and those patients that were wanting to quit smoking were referred to Project Vida and other tobacco cessation programs. And currently we have a new standard of the Hospitals of Providence, a new way of reaching out to the population in our communities. So now part of it is we integrated, and we say we because it's a collaborative effort, and they, through their EHR, they now flag those who are smoking. And so they are referred to the respiratory department. And so now the respiratory department are in the works of getting them trained for tobacco cessation to go ahead and provide those resources. And then, of course, if they qualify for the screening. And this is system-wide. So it's something that they're going to do. So that's, I think, a huge, huge improvement in the work that we're doing around lung screening.
Well, it really sounds like a great program, and we're so thankful that the American Cancer Society was able to really focus in on the El Paso region and look at it systemically. Jennifer, I want to hand it over to you. What stood out to you in our report?
So there are several factors in the report that really stood out to me. The first one was, where Texas ranks when it comes to incident new cases of lung cancer, and comparing that to our degree of screening. While we can pat ourselves on the back that we are closer to the top tier when it comes to new cases, if you think about it, if we're not screening people and less than 2% of people are being screened, we're not identifying the cases of lung cancer. And so our numbers may actually be higher than what the data suggests, because what we're doing is we're catching people at late stages where they're symptomatic. And we know that there's a wide variation of time between when cancer starts and when people start to have symptoms. And so that's one thing to remember. A lot of the other numbers, I think, also follow what we see for minorities, which is even where they have lower incident rates for cancers, less likely to receive screening, less likely to be diagnosed at early stages, which would improve mortality, and less likely to get a standard of care treatment or to avail of a standard of care treatment, which is really sad overall.
Yeah. Now, Jennifer, I understand that you and your team are benefits of a CPRIT grant, the Cancer Prevention and Research Institute of Texas. And for those who don't know, CPRIT is a state agency. CPRIT is a state agency here in Texas dedicated to directly funding cancer research, cancer prevention, and bringing researchers and companies to Texas. So first, congratulations to you and your team on those grants. Now, I know while your grants may not include lung cancer, what are you learning about improving access for other cancers?
And so our first screening grant, which is a colorectal cancer grant, was first funded in 2011. So we have over 10 years of experience when it comes to cancer prevention, cancer screening, and what is important to our community. We started with doing a lot of stakeholder discussions and meeting within the community to understand what the problems and barriers were. Martha has been very involved in some of our processes, just really understanding it. We go to the community where they are at. You know, as Martha has mentioned, in El Paso, we have a very high rate of uninsured or underinsured individuals. We have access barriers, we have language barriers. We lean very heavily on the use of community health workers, otherwise known as promotors or promotoras here, so that people are able to receive education and outreach in the language that they prefer, from individuals that are from the community who understands their concern. What we find is that people are able to be open about their fears, their concerns, and their barriers, which then assists us with navigation. As just an example of one of the programs. So for example, for the colorectal cancer program, since inception, we've enrolled over 42,000 people. We've had over 40,000 people complete a screening, and almost 1,000 people who were diagnosed with adenomatous polyps. And if you think about colorectal cancer, those are pre-cancer stages. So those are almost 1,000 individuals who have had cancer prevented in them by being able to identify those polyps early, remove them, and put them on a path of a more frequent screening so that we're able to identify and remove new polyps before they become cancer. None of this, we wouldn't have been able to do any of this, one, without the support of our community agencies, our FQHCs. We work very closely with Project Vida as well, without, of course, the funding from CPRIT, which allows us to provide free services to uninsured and underinsured people, but also allows us to navigate people with insurance to ensure that they are going to complete their care.
Yep. Jessica, I'm going to kind of hand it back to you. We've talked a lot about kind of the struggles of meeting folks where they are, that, you know, maybe getting them that first doctor visit and sign up for cessation is one thing, but that second obstacle of getting to the screening. Can you talk to us just kind of how what are some of the struggles you've faced in meeting people where they are and making cancer screenings a priority in their already busy lives?
It's just, you know, reinforcing, you know, if we come the first visit and we talk about it's not a priority, it's not giving up on that patient. I think if there's one thing that I learned from my supervising physician, Dr. Garza, is just it takes time for people to understand the impact of smoking, right? And if it's not a priority the first visit, don't forget about it on the next visit. Continue to push and remind them, hey, you still need this screening. But another thing that, you know, even Martha said is the transportation. I think that's a big one in our population, especially me on the mobile unit with the homeless, is the transportation. You know, things like meeting them where they are, as Martha mentioned, offering a ride is also a big deal when it comes to them taking the bus or taking 3 or 4 buses to get, you know, to the central if they live far east or west. So we just have to continue to remind them, and then offering, you know, services like transportation as well. I think that's a big one, which I know they're very grateful for.
Absolutely, absolutely. Martha, you've been on the ground in El Paso working on this for I think close to 2 decades. I mean, what works well at the local level, and what more can we continue to focus on to increase these screening rates?
Well, just like Dr. Molokwu said, promotoras. These on the ground women and men, because there are promotores too, you know, they are key to bringing people in for screening. Like mentioned, I think the language barrier is a big thing. And so as a Hispanic population, you feel like you can trust someone that is also Hispanic telling you about, oh, colorectal screening, you know, oh, your mammogram. And I think that has worked, and you know, it attests to the work through CPRIT and how effective they've been through that work, which I believe also through lung screening. As you can see, lung screening is a little different, right? The guidelines are a little different. It's harder to mention someone, you know, are you 50 and over? And, you know, do you smoke 20 plus? And so that is very hard to target in our community right now, because, and what I've seen, it's different from you're 40 and over, you're 50 and over, you know, you're 45 and over, screening for a mammogram, you know, colonoscopy, flat, simple. But when it comes to lung screening, the barriers that we do see is that patients don't want to get screened, or those who are part of the criteria. Oh, I don't smoke 20 packs. I only smoke like 10 packs. So they diminish their own, they diminish that criteria because they don't want to get screened because of the fear behind it. And I think that is why I think we still need a lot of improvement when it comes to getting them to screening. But I also think that promotoras and incorporating that, you know, and it's fairly new in the market, you know, in El Paso specifically, we just started last year. We're gradually still seeing that improvement, you know, we're seeing that, but there's, like mentioned, there's a lot of work to be done. We're, you know, working with our providers, provider trainings, evidence-based interventions such as provider trainings, you know, client reminders, patient education. All those will enhance and help, hopefully in the next couple of years, and we'll see those numbers rising, you know, and decreasing in others. So
absolutely. Back to Jennifer. What are some of the barriers for your team in expanding lung cancer screening? Is it purely a funding issue, or is it more complicated than that?
It's slightly more complicated than that. It's providing the bandwidth. We have been very successful in the cancers that we are screening for. It's recruiting more individuals who are interested in introducing the cancers, because sometimes you don't want to stretch yourself. It's not that lung cancer is not an important problem, but you want to make sure that you're doing what you do well. So kind of growing our unit so that we have more people, so that we make sure that when we are applying evidence-based interventions to get the community, that we tailor it to that particular high-risk group, right? Even though we use a similar process, you know, we use evidence-based education that we develop tailored with our community in mind. We try to target things that have been mentioned here, people's perceived susceptibility. Am I at risk for getting this cancer? The perceived severity of the disease, things like fatalism, right? Or if I get diagnosed with it, I'm gonna die anyway. And so it's better not to know. And so we actually create our education to target those psychosocial variables and to those high risk groups. And so making sure that we're doing a great job of targeting into that. And so as we expand our capacity by getting more folks involved in our group, we will start to look at those cancers that we haven't been looking at previously.
You bet, that makes sense. Well, I just want to pause and encourage our audience, if they have any questions for myself or our panelists, feel free to put those in the Q&A or the chat box. I've kind of run through my questions, so while we wait for any extra questions, Martha, Jennifer, Jessica, anything else you'd just like to add on this topic before we wrap up?
Yes, Charlie, I want to mention also, give a lot of credit to both Texas Tech UMC and also Hospitals of Providence. They did partner with us on a lung screening biomarker testing echo project. They're very active in this. And part of the ECHO project is to really share, you know, their practices for lung screening, the improvements, case studies. As you know, biomarker testing has been signed and can now, you know, the American Cancer Society can now really focus a lot, and now with partnership with you all, really focus on biomarker testing and options now for better treatment, right? Especially in lung screening. You know, and so this is something that we want to go ahead and pursue and continue. So hopefully we can, you know, but I did want to mention they are very active in our ECHO lung screening project for biomarker testing.
Well, and you bring up a great point, Martha. We've, you know, obviously Texas is a hub of medical innovation. You know, Dr. Jim Allison, immunotherapy was brought here to Texas. We've got all these great new treatments and great new tests like biomarker testing. But if we can't get that initial screening, none of it matters, right? And so obviously a lot of great stuff's happening on that end, but we need more attention focused on the screening. Thank you. Jennifer, Jessica, anything else to add?
No, I just wanted to agree. You've hit the nail on the head that we have to get more people screened. We have to diagnose lung cancer early so that we can get the treatment. We have to put things in place for preventive things like smoking cessation. And we have to get those who are diagnosed to treatment. I think that of all of the statistics, the most heartbreaking statistic was the 32% of people who are diagnosed with cancer who are not undergoing treatment. And so that just shouldn't be happening, and understanding what the barriers to that is. Is it cost of treatment? Is it that fatalism that can sometimes happen? And it's especially with lung cancer. I think there's some cancers where people think, okay, yeah, there's hope. But there is that sense that lung cancer is just one of those with a high mortality. And once people hear it, it's like, I just need to be getting my affairs in order rather than looking for treatment. But having people understand that there are new immunotherapy and other genetic treatments that are coming on board, and that the science is growing in leaps and bounds. And so giving hope to the community so that people are willing to undergo screening and testing and navigating them to treatment, at least to start those discussions as to what their options are early on in the process.
Yeah, yeah, and not to put you on the spot, would you agree that probably that lack of treatment rate is lower for other cancers than it is lung cancer? Lung cancer is probably one of the highest lack of treatment percentages.
Oh, most definitely, most definitely. I would say, I mean, I was shocked when because I read the report before I hopped onto this meeting, and I was shocked. As a clinician, I was totally blown away to see that statistic that 32% of individuals are not going through. I mean, you could have knocked me over with a feather. That for me is a shocking number. And I wouldn't imagine any other cancer having close to those numbers of treatment, of lack of treatment.
Yeah, thank you. Jessica, anything else to add?
No, I'm just grateful for you putting this together and for the collaboration. I know with Martha, Texas Tech, Hospitals of Providence, and so this is a great. Thank you for bringing us together. Thank you.
You bet. All right. Well, I've just got a little extra information for everyone. And so before I go, I wanted to share some resources. And just give me 1 second here, make sure I have the right information. So the lung helpline, 1-800-LUNG-USA, the lung helpline is staffed. Oop, I'm getting a bit of feedback. Jennifer, would you mind muting real quick? Thank you. The lung helpline is staffed with licensed registered nurses, respiratory therapists, and certified tobacco treatment specialists. In addition, there are bilingual Spanish-speaking staff along with a live language interpretation services for over 250 languages. So our knowledgeable staff have a wide range of experience in the healthcare industry, and it's our mission to provide thorough answers to all your lung health related questions and connect you to the resources you need. While it is not a 24/7, it is open Monday through Friday, 7 a.m. to 9 p.m. Central Time, and even on the weekends, 9 a.m. to 5 p.m. Central Time. And I have a note that after hours, please leave a message and we will respond by the next business day. And there's also a different number for those with hearing impaired. Now, I did see a chat come through that I wanted to just take a look at. Is there an initiative to go directly to the public with messages by putting out the criteria for lung cancer screening? I'm sure there are. I know the American Lung Association is trying to do part of that, but to our other panelists, are you aware of any other public messaging campaigns around lung cancer screenings?
Locally or nationwide? Locally?
I would imagine either
Locally.
or, probably. Yeah, probably locally.
No, but that's a great question. The reason why this is something that could be in partnership with, many of us, that we can push that. So thank you for that question, because that is something that our communications department, a new program that just came out, Get Screened. And so maybe that might be something that we can all work together on.
Perfect. Absolutely. Great. All right. Moving ahead. Last July, the American Lung Association released a new billing guide to help public health and healthcare stakeholders better understand lung cancer screening coverage and reimbursement. This billing guide includes information on coverage requirements by type of health insurance, coding and documentation requirements, smoking cessation interventions, implementation challenges. And so you can find more information at lung.org/lung-cancer-coverage. And then we also have resources at lung.org/open enrollment for help understanding and accessing the often confusing health insurance market. I also wanted to flag a great collaborative opportunity. The folks at MD Anderson are looking for lung cancer screening center partners who want to build their tobacco intervention capability. Project Switch, supporting workplace investments in tobacco control and health, is a comprehensive CPRIT-funded program. And if interested, you can scan the QR code or send an email to the email listed right there. And I'll just pause for a minute in case anyone does want to take a picture of that QR code. Okay. And then finally, thanks to funding from the Center for Disease Control and Prevention's National Comprehensive Cancer Control Program, the Cancer Alliance of Texas is working to implement the state's cancer control plan through the Texas Comprehensive Cancer Control Program. They are surveying lung cancer screening programs in Texas to better understand the scope and availability of services provided by these programs. And so we encourage anyone involved to complete the survey and or help disseminate the survey to your colleagues who are members of lung cancer screening programs in Texas and El Paso. Persons completing the survey should have pretty good knowledge about their facility or institution's lung cancer screening programs, components, processes, activities, and resources. And so if you have knowledge about your facility or institution's lung cancer program, please consider filling out this survey. I'm going to drop a link to that right here in the chat box. Give me 1 second. And I'll be sure to include that in my post email information. And so without further ado, I will close this out by handing it over to Charlotte Mafia, who is our Texas Executive Director, for some closing thoughts. Char?
Hello, everyone. I wanted to thank you all for participating in this panel and the roundtable. This was something we wanted to bring to El Paso, so we are happy to do this. And also, I want to thank our sponsor, Betsy. Are you still on the call? Would you like to say a few words?
Give me 1 minute and I can unmute Betsy if she does want to say anything. Okay, Betsy, you should be able to unmute if you'd like to say a word or two, or just a hello.
Hi, everyone. I'm just really happy to be partnering on behalf of Genentech with y'all, so we can continue to advance the work that all of your organizations are doing. So we just appreciate that collaborative effort. Thanks, Charlie.
Again, thank you, and thank you to our panelists and to our facilitator, Charlie. He did a wonderful job. We're happy to have him. Actually, we're very fortunate to have him with the American Lung Association. This is just the first of our roundtables. You know, Texas is a large state, and we want all of our communities to feel like we appreciate them, and we want to educate them as well. So more to come in the future, but this is one of many. So thank you all, and a special thank you to you, Charlie.
All right, well, thank you all again. Thank you to our panelists. Everyone, I hope you have a wonderful rest of your day and a great July 4th weekend coming up. Goodbye for now.
Thank you.